Welcome. My name is Michael Lucido, and I'm a physical therapist, and I am a teacher and instructor with the North American Institute of Orthopedic Manual Therapy, also known as NAIOMT. Today I'm doing a series of videos that will primarily be used for our online education. And I'm using these videos, as I call these, the best of NAIOMT, the best of the North American Institute of Orthopedic Manual Therapy, giving you a taste of some of our different theory and practice that would then give you a sense of where we're going as an institute and whether you'd like to join us or not. Another technique we can take a look at introducing our institute to you is a person who has anterior shoulder pain. Anterior shoulder pain is a complaint that many shoulder patients actually have, and many times it's actually coming from a mechanical shoulder problem. There are some times too that this could be a more complex problem coming from a poor motor control coming from the foundation of the shoulder, which is actually the scapula. So this particular technique assesses the muscle length and muscle control of the scapula that could be playing a role in the person's anterior shoulder pain. So we're going to look at this particular patient. We've done a shoulder examination already on him. Yes, he's got some tenderness in the front of his shoulder, but there could be other confusing type or inconclusive type findings in a shoulder examination, which brings us more to taking a look at the foundation of the shoulder. So we're going to go in and take a look at movements of the shoulder blade or the scapula that really should have the mobility and the flexibility to allow the shoulder to function properly. Ideally, the vertebral border of the scapula should come all the way back to the spine. You can see he actually does that fairly nicely. And this is actually checking the length of the serratus anterior muscle. Another way of assessing another very important muscle is the levator scapula. So if I come down and do a downward depression of the scapula, and I feel like this is being caught, it's not allowing proper glide, the scapula in a young 18-year-old should have a lot more movement here. I might consider that the levator scapula is actually keeping it from doing a normal mechanical movement of the scapula. I could then go in and do a stretching technique on the levator scapula and then reassess. So I'm going to keep Luke's arm just like this. I want to come around the back towards the head, and I'm going to put his levator scapula on stretch. The levator scapula is coming into the superior angle of the scapula, coming up, turning on itself and attaching upper into the upper cervical spine at C2, C3. I'm going to come down, depress the scapula, putting the levator on stretch, and then keeping that superior angle really inferior by pushing a lot of pressure with my thumbs, keeping that position. While I'm doing that, I'm going to provide upward rotation of the scapula and really providing an additional stretch. Now I'm going to have my model turn your head to the left for me, Luke, and then bring it back to neutral. Turn it to the left, and then back to neutral. Every time he turns his head, you can feel an additional stretch on the levator scapula. I then can go back into assessment of the shoulder blade and see if I feel any difference in the amount of movement, especially when I go into inferior glide and upward rotation of the scapula, which is a very functional movement. And again, I would have the patient stand up and see how his anterior shoulder pain feels after moving it several times, after we were able to elongate the levator scapula.